Okay, very good, Cedric. What an interesting presentation. And we're moving forward with robotics and AI, and probably soon we can have an artificial heart transplanted and save so many lives. We have been seeing here that there are many steps we can take in order to avoid getting to that point. So now it is my pleasure to introduce you Dr. Victor Urrutia. He's, okay, I have it here. He's a professor of clinical neurology at Johns Hopkins University School of Medicine, director of the Comprehensive Stroke Center at the Johns Hopkins Hospital, director of the Sheikh Khalifa Stroke Institute, and medical director with Johns Hopkins Medicine International, founder and director of the Global Center for Organized Stroke. You are also head of the program here in Panama at our hospital, Pacifica Salud, right?
I'm medical director for the affiliation.
Medical director for the affiliations. Okay, if not, Antonio is gonna kill me if I don't say it. Welcome.
Thank you for that very kind introduction. I don't know if the people that speak English outnumber the ones that speak Spanish. Maybe I should just speak in English, as everybody has done. So I'm going to talk about how the time, the need for speed, the technology, AI, and telemedicine is being integrated in stroke care. So I'm going to try to go this briefly. These are my disclosures. And I asked ChatGPT to create a slide with the quote, "The future is already here, it's just unevenly distributed," from William Gibson, who, if you don't know him, you can read a book. It's a cyberpunk novel called Neuromancer, which was published in 1981. And it's going to feel like yesterday's news. But the truth is that everything that I'm going to talk about and everything that most people have been talking about today can be done anywhere in the world, but often we're faced with situations like this one, and this one, which is a real life picture where you can have AI, which is being used at Punta Pacifica, but in the same city, you may not have the resources to use it or to use any of the other treatments that are not even that advanced technologically. Now, just a little quick primer, in terms of artificial intelligence, it encompasses a lot of things. It's basically, the basic is machine learning, where computers develop algorithms to predict what the answers is, what the answers are, what are the right answers based on the large data sets. So it helps us really be able to take larger data sets than what we were used to and make good predictions, as Dr. Wilson was talking about in terms of health risk, for example. Natural language processing has been very useful, and we're using it to identify data points in electronic medical records, for example. Also in ambient recordings to create clinical notes. In the large language model are what most people know about ChatGPT, and I think it's going to a next level with Claude. And the last two, generative AI and neural networks are in use for the most advanced data evaluations that AI can do. And generative AI is something that is emerging that I think it's going to be bringing a lot of changes. One of the things that I think is important to understand is the two types, although there are more types, but these are the most common. Supervised learning, where the computer, the program, the AI basically learns from data that has been classified, grouped, and clustered by humans, and then learns to do the same thing that the humans are doing. And then unsupervised learning is what AI does and what promises to, for example, look at a catalog of molecules and determine which could be potential treatments for a specific disease. And finally, a point that I want to make is that in healthcare, I think the role of AI is the most regulated than all of the roles of AI out there. We have been using AI for a long time in social media with terrible effects for society. But in healthcare, at least in the US and at least until a few years ago, there's been a very well-structured way to develop, train, validate, and then approve medical applications of artificial intelligence. Now, going back to stroke, stroke is the second leading cause of death in the world. And so it's a problem that is not just for the high-income countries, it's really everywhere. In fact, in the US, it's been the fifth leading cause of death for the last 20 years. Whereas when I trained back in the 90s, it was the third cause of death in the US. And but it's still the most expensive condition paid by Medicare, which accounts for 60% of Medicare billing. So it does have a significant impact. Half of the people that have stroke survive. So it does create a significant problem in terms of lost productivity, family issues, social issues. And in lower and middle income countries, it's actually far more common for stroke to happen at a younger age. In the Middle East, which I'm really familiar with for work that I've been doing there, the median age for stroke is in the late 40s. So it's significantly lower than in high-income countries. Although those are high-income countries as well, but what I like to call emerging high-income countries like Panama. So there are two types of stroke, ischemic and hemorrhagic. Ischemic is the most common and therefore has really garnered a lot of attention from science and studies and in terms of therapeutics. And the two acute treatments for stroke that are able to decrease the disability and the mortality are intravenous thrombolysis and mechanical thrombectomy. Mechanical thrombectomy became evidence-based in 2015, and already in 2018, it extended to 24 hours in terms of the window for treatment. And it's a very effective treatment with the numbers needed to treat of 4 in general terms, and very selected patients, even 2. Which is a really high number considering that PCI has a number needed to treat in the 30s. Now, intravenous thrombolysis has always been limited by time to 4.5 hours or less. Initially, in 1996, it was less than 3 hours. But this year, with the new guidelines and a number of studies that have been published, it has been extended to 24 hours with advanced imaging. And that advanced imaging uses AI. Now, the care of stroke is complex, and it requires a system of care that needs to be developed. And I always, when I speak, especially in other countries outside of the U.S. or Europe, I say that you have to learn to walk before you run, and rather than focusing on the high-end AI applications, technology, telemedicine, you need to organize the system of stroke, which is really not expensive and in itself is a treatment that decreases mortality and disability by 25%. But as you can see here, it's very complex. The center is the Certified Stroke Center. That's the core that allows you to take care of all the aspects of stroke care. And in a system of care, it's best to organize hospitals as individual stroke centers and then interconnect them to be more efficient. Now, this is a picture from the latest guidelines, and it shows you, you can see that in pretty much all the steps from stroke awareness, stroke detection, EMS and pre-hospital care in the emergency department, and then early imaging, early rehabilitation, early management, there are AI applications for all of these steps. And again, it's becoming very useful and very much widespread. As I said, here in Panama, we have hospitals that have the ability to interpret imaging with AI, which speeds up the treatment. So I'm moving to telemedicine now. As I mentioned, even though now we have windows of treatment up to 24 hours, the faster you treat the patient, the better the outcomes are going to be. And especially in rural areas, the access to emergency stroke care is limited. These maps, the yellow blotches, are access to thrombolysis in the left-hand side panel within an hour, and access to thrombectomy in the right-hand side panel within an hour. With telemedicine, we are definitely improving the access for patients in those white areas that are not near any stroke centers. And that we are also speeding up the process for them to get mechanical thrombectomy by transferring the patients, once evaluated by telemedicine, to an appropriate hospital. And this is an old study. Right now, there are many more telemedicine networks. They're all based on video capabilities and a review of imaging. However, I want to say that we have been able to, based on the way the field has been moving, to bypass the video at Hopkins. And the way we've done that is that if you look at the early studies, which are on the left-hand side of the screen, they compare telemedicine with video with telephone, just talking to the person over the phone and giving an advice. No review of imaging, no protocol, and clearly video was better. In fact, there was a lot of emphasis with the video machines and the robots that allow you to see the patients, that those videos were good enough to look at the pupils and the images in the view boxes, which are a thing of the past. And the newer studies are showing that if you have standardization of care protocols, organization of the stroke system, you don't need to look at the pupils. You just need to train the emergency medicine physicians to do an abbreviated exam that tells you the situation. You look at the images online and you give a recommendation that is just as effective. And we have shown that with our telestroke network, which does not use video. And we cover Bermuda, for example, the one hospital in Bermuda, and give thrombolysis and guide therapy by looking at the images and talking on the phone. But we have trained the emergency medicine doctors to be able to look at a patient that has a possible stroke, examine them, and give us the right answers to the questions that we need to make the decision. And the adjuvants to all these telestroke and acute treatment decisions are many, as you can see here, applications that allows us to quickly detect large vessel occlusion, and we get an alert, and we can start moving everything even before the emergency medicine doctor knows that the patient has a large vessel occlusion clinically. And there are other applications of AI that are helping with rehabilitation and reintegration to the community, as well as diagnosis. One of the areas that are difficult to diagnose still are patients with dizziness or visual problems, because they represent a large proportion of mimics, and the few of them that are strokes are hard to find sometimes. We're also using AI to optimize our clinical processes. So you can take an AI and train it on the data on your workflow and find the important steps and find which are the avenues or the steps in the process that predict a faster achievement of the next step and a faster, for example, door to needle time or door to groin puncture time. So that's one way that by the traditional way that we do this is that we look at the spreadsheet and we start looking at, well, you know what, there's a little bit more delays in reading the CAT scan. And the AI, what can do is can look at a vast number of data more than we can look quickly and tell us, okay, well, it seems that if you don't do this first, you're not going to get to that time window. And that's another way that AI is helping. We've looked at this at our place, and others have looked at the same thing. You know, the application of AI for detection of large vessel occlusion and other imaging characteristics do help speed up the times to treatment. And now we're trying to move a lot of what has been traditionally the workup of stroke in the emergency department to the pre-hospital setting. And that's where we're seeing the use of mobile technology like CAT scanners in an ambulance combined with telemedicine to be able to make decisions quickly and treat patients in the field before they even get to us. So the model is that you would treat patients with IV thrombolysis, and then if they require thrombectomy, they go directly to the center that has thrombectomy capabilities instead of going to the closest hospital. And there's a large randomized trial that showed that this approach improves functional outcomes significantly, and also the time to treatment within 60 minutes was 32 versus 2.6% in the patients that were treated in the standard way, going to the emergency department first, being evaluated there, and then treated. It is cost effective if you consider the patients that are first-time patients, and also the more you use the MSU, the mobile stroke unit, the more cost-effective it's going to be. If you use it for just a few patients a year, it's not going to be cost-effective. So like anything, economies of scale are important. And one of the things that has become evident is that this approach is not only beneficial for ischemic stroke, but also for hemorrhagic stroke, because once you detect that you diagnose the patient as having a bleed as opposed to an ischemic stroke, you can immediately lower the blood pressure in the ambulance, which is something that we avoid doing normally, because for ischemic stroke, which is 85% of the strokes, lowering the blood pressure is going to be harmful. So it really steps up the diagnosis to the field, so you can start lowering the blood pressure before they even get to the hospital and reversing anticoagulation. And the challenge here is that we have two modalities of the same pathological process that are treated in diametrical opposed ways. So one, you use thrombolysis, the other one, you reverse anticoagulants. One, you keep the blood pressure up, the other one, you lower the blood pressure. And with that, I'm going to just end with a few thoughts that, you know, a lot of, you see in the media, you know, I get asked in barbecues and parties, well, are you worried that the AI is going to replace you? And I think that we all know in this hall that AI is only likely to replace doctors that don't use AI. It's a tool like every other tool, and I think that we're going to keep using it, and it's going to help us. It's going to be more like TARS from Interstellar than HAL from 2001. Thank you. I promised that I was going to be fast, so